So thank you, Jennifer. The next case is being presented by Dr. Claudia Montanaro, who is the newest addition to the consultant body at the Brompton. So welcome, Claudia. We'll head straight in, and if you share your screens, please present the next
Hello,
case.
good afternoon. Just 1 second, I try to share the screen. Can you see my screen? Can you see my screen?
Yes.
Okay, perfect.
Yes.
I think you have. Can you still see it? No, you can't.
No, it just jumped out.
Sorry.
Okay.
Let me do it again. Can you see it now? Can you see my screen?
Yes.
Good. Fine. So this is a much, I would say, a shorter case compared to the previous cases, and it's very much for discussion. So this is a 24-year-old lady, and her diagnosis is CCTGA, non-restrictive ventricular septal defect, severe pulmonary valve stenosis. And she has history of arrhythmia with dual AV node physiology with 3 previous ablation for AV and RT in 2016. And this patient has not received anatomical repair of her cardiac abnormalities. She's currently only on the Altazam, 240 milligrams, and she's in NYHA class 1. She denies breathlessness, pre-syncope or syncope. She's actually very active, attends the gym 3 times per week, and where she does cardio and weightlifting. So now Ms. HD wants to become pregnant. And so the main question is, what's her risk? So what's her risk based on the new pregnancy guidelines, and what is her personalized risk? So if we look at guidelines, she's an unrepaired stenotic heart, and so her maternal risk will be between 19 and 27%. So the question that I will shortly ask you is, would you counsel the patient against pregnancy, or would you strongly recommend that the patient does not get pregnant at all? But before doing this, of course, I'll give you more clinical information. The patient's weight is 101 kilos, and she's 177 centimeters tall. Her BMI, therefore, is 32. Her ECG shows that there is a sinus rhythm with heart rate of 81 BPM. There is a right heart axis deviation and a QRS duration of 119 milliseconds. This is her recent chest X-ray. So overall, the heart is not that enlarged. And here we have an echocardiogram showing that the systemic right ventricle function is preserved. There is no significant AV valve regurgitation. This on the right-hand side is a better view of the short axis and the radial component of the systolic function. The patient has an unrestricted VSD, as you can see again from the short axis view, and there is a severe pulmonary valve and subvalvular stenosis. So this is all in all a well-balanced heart. Her saturation at rest is, we will see in a second. Yeah. So we have an MRI. The MRI done in November 2019 again shows that good radial function, good longitudinal function with a very minor AV valve disease. And here we see a significant pulmonary stenosis. The ejection fraction calculated for the right ventricle is 65, for the left ventricle is 71. So all in all over 60% ejection fraction. The patient undergoes cardiopulmonary exercise test in order to stratify her risk for pregnancy. She does exercise for 9.5 minutes on a Bruce protocol. So this is not a modified Bruce protocol, it's a proper one. So 9 minutes is quite impressive. She managed to achieve maximal effort with an RER of 1.06. Exercise is stopped due to shortness of breath. The peak VO2 is 91. The oxygen saturation at rest is 94, and she desaturated down to 80. Blood test, recent blood tests show that her hemoglobin is 154, so slightly increased. The BNP is 31 only. There is no iron deficiency. So now this is a question for the panel and for the audience. What would you, would you counsel the patient against pregnancy? How would you judge her risk of pregnancy given the data that I've just showed you?
That's great. Thank you, Claudia. I'm not sure if the poll is open. I'm just trying to, I'll find out in the background. But Professor Wald, I don't know what your initial thoughts might be on this case.
Not being an adult congenital specialist, but even though it sounds as if this is high risk for pregnancy, but not my specialty. I will defer to my ACHD colleagues for this question.
Of course. Thank you.
So points in favor of pregnancy, I guess, are a good functional. So functionally, day to day, she is fine. And she did reasonably well on her exercise test, but clearly the degree of cyanosis is a concern, although her hemoglobin is not very high, and which would suggest that she, is not significantly cyanosed for the majority of the time. Prof, what would your thoughts be? I'm just wondering in the back of my mind whether something like a exercise stress echo might also be useful, just to see what her RV function does with a more physiological test.
I think this is a great case, isn't it, of no intervention. She's made to her 20s, early 20s. And I think Sarah Conim alluded to this on the gentleman who presented with VTVF in his 40s, that he had elective physiologic repair at the age of 12. When you embark into this, then you commit yourself to further intervention. Sooner or later, many of these patients then require tricuspid valve replacement, which he actually had, with a big interval, as Sarah indicated. When he talked to the patient after admission, the one from Wales, he said that she was much better after his operation. But he survived to the age of 12 or 13 with that balance, double discordance of a kind. This patient is functioning very highly. It wasn't a maximum test. I think, Natalie, you're absolutely right that we see some desaturation with exercise, but your hemoglobin is not particularly high. She's not iron deficient. And that's a very, if there is a profound cyanosis, then that drives your hemoglobin crazy, which it doesn't have. And she's got good biventricular function. She's got no valve regurgitation. So she's got a heart which is not very large on the chest X-ray. Do you have her BNP by chance, Claudia? I don't think
yes, it was 31.
So this is marginally elevated. So, I guess the first question to ask is, forget her gender, and whatever you decide in the past with what we see right now, what is her prognosis if we leave her alone or leave him alone if it was a male patient? And you do have patients with this in their 50s and 60s who still fare reasonably well, albeit some cyanosis, you see some progression on this. So, yeah.
I think
Well,
you anticipated
what's
my
her shunt fraction? Sorry,
Sorry?
Claudia, what's her shunt fraction? What's her shunt ratio through her VSD?
So it's a single ventricle physiology, and I can double check in a moment for you. But it was
we can probably talk about it from echo. She does have obviously significant left-right shunt. This is biventricular heart. She's got a significant shunt, and that's why she's got a good saturation, Joyce. But you're making a potent point whether eliminating this shunt, this volume overload, would convey benefits in this complex balance that you see, which is for her right now. I think she's very well balanced. In my mind, she's not a high risk subject if she were to become pregnant with this. But people beg to differ, and this is uncharted territory. Natalie, this is up to you, Ali. Tell us what you would do with her at St. Thomas's. You're the pregnancy lead there. What do you think?
So I think I agree for the mother. I think the risk appears to be relatively low. But as I was just going to ask your question, actually, in response to a comment from Lisa Freeman, which is absolutely right, is that the risk is just as much to the fetus in terms of the patient's desaturation. So if you were counselling this patient, what would you ballpark, or what information would you give her about the fetal risk as opposed to the maternal risk, which I think, assuming that the RV function doesn't change significantly during pregnancy, would, I think we agree we would be happy to support the mother, but what would you quote in terms of fetal risk?
Well, definitely we know that there is, well, if I can start with an answer, and then obviously I'm very happy to hear the other panelists. I definitely do counsel the patient mentioning the risk of hypoxemia related to the fetus. So first of all, there is potential difficulties for her to get pregnant, or to have an early miscarriage. And then I have mentioned actually all the risk related to low maternal saturation related to fetus. So I think that the balance here is also based on the wish and the background of a patient. So how strongly a patient wants a child, what is the risk that the maternal and fetal risk the mother is ready to undertake. And I think that as long as all this is explained correctly, then we are here to support the patient. We personally see these patients very frequently, like every other week, and this is the way we try to prevent complications. I think this case in particular is interesting for two reasons. One is the pregnancy risk, but the other, and so the counsel is, but the other thing is, should we, or what people think about doing a correction in a view of a pregnancy or a view of long-term results. And I personally think that, as also Professor Gazzolis mentioned, this is a very, very well-balanced case. And sometimes repairing complex lesion will give a very nice echo view, so with two ventricles, no pulmonary stenosis, etc. But the long-term outcome is not necessarily better. And this has been also demonstrated, for example, for in the pulmonary atresia groups, which is another complex group. And there is we published a couple of years ago a large cohort of patients, and there was no difference in the long term between those who were repaired and not repaired. So I think sometimes we need to look at balance of the heart, and we need to think what is the best for the patient rather than the nice picture on the echo. I don't know what the other things about this patient's counseling, or if they would do it differently.
I guess I'm contradicting myself, and I'll invite Andreas to comment on this too. In that, I think Joyce alluded to this. There's a large shunt, which I think in the long term is not necessarily a good thing. And there may be a case, to argue for, of contemplating palliative repair, but not relieving the right ventricular tract obstruction, the left ventricular tract obstruction, so that maintains some balance in terms of the septum, and then eliminating the shunt, improving saturation. And that, in theory, may be beneficial to the patient long term, albeit these are highly selected cases. So contradicting myself here, but I would invite Andreas to comment.
Thank you, Michael. My views on this would be that I would have a very conservative approach to this patient cohort. I think it is very difficult to get the balancing right to prevent progressive tricuspid regurgitation after you relieve some of the obstruction. And therefore, the native obstruction is probably the best regulator and preventer of long-term tricuspid valve dysfunction. If the patient clearly has signs of pulmonary overcirculation with wet lungs and is struggling, then I think you wouldn't find the patient to have this level of saturation. I think the saturations would be persistently higher than this. So I think I would be very, very cautious, and I would not be keen to offering this lady a palliative operation, certainly not at this age, because I think any type of surgery for corrected transposition, I am yet to see that there is actually a significant survival benefit of doing that in an adult age group in any publication, other than a transplant, which I think she's far from requiring.
We actually joined the patient with Claudia and said that the risk to her is not prohibitive in terms of becoming pregnant with where we are right now. And pertaining to the question, I think important question that Lisa Freeman is asking from Norwich about the risk to the fetus, I think we don't anticipate a full-term pregnancy here. And there will be a small, properly infant for dates, baby for dates. We're planning to suggest thromboprophylaxis for the patient clearly during pregnancy. But I think with the right management, perhaps restricting some activities towards in the third trimester, I think there are reasonable chances for this patient who has normal saturation, 95% at rest, and no secondary erythrocytosis, to be able to give birth to a child, albeit prematurely and small for dates. But again, this is speculative to some extent. Would you agree with that, Natalie, or would you have a different view?
No, I agree. I think one would watch her very closely and the fetus during pregnancy, and one of those cases where you never make any definite plans, but modify the plan as you go along. But as as we've mentioned, and as Lisa's mentioned in the chat, careful monitoring, watching her saturations, fetal growth, the BMP, in terms of her RV function.
And what she must do, colleagues and delegates, and she registered that, is lose 20 kilos. I come back to what I said at the very beginning of this meeting, particularly for patients with systemic RV with a single ventricle physiology. The best thing that the patients can do, including those on a transplant list, is to be slim and athletic as much as they can. So she needs to save 20 kilos. And I think she registered with this, Claudia, didn't she? So she's an intelligent person. You're muted, Claudia, sorry. Claudia, you're muted, so we can't hear you. Can you please unmute, Yanis, can you please unmute Dr. Montanaro? Say that again, Claudia, please. I couldn't hear you.
I was just saying exactly that we discussed in length this issue, which is actually a major issue. I mean, the obesity is per se a risk factor, not only for pregnancy, but for her long-term prognosis. And so this is something on which we can work actively. And the patient is an active person per se. So what I've encouraged is to start a proper healthy diet, and along with also increase the aerobic exercise rather than the weightlifting, which are probably not extremely beneficial for her. And I think this is something on which we can work with no downside, but only positive side. And probably that will help her to have a better prognosis.
Yeah. I think I'm afraid we will have to call it a day, because we need to have a bit of an interval. And I thank all the presenters. I think the team has done a fantastic job. There were